for joining us for this week's episode of Mommy Talks. Today we are joined by Dr. Saira Sakwalla, an endocrinologist at the MP Shad Hospital, to discuss about gestational diabetes. Stay with us.
Gestational diabetes is a type of diabetes which occurs specifically during pregnancy, due to pregnancy, and usually resolves immediately after pregnancy. Gestational diabetes is a very specific term for that diabetes which is brought about due to the pregnancy. Okay? Usually diagnosed between the 24th to 28th week of gestation or after. Sometimes women present late, so it's diagnosed later. Okay? And there are specific cutoffs to differentiate between gestational diabetes and diabetes pre-existing before pregnancy.
What are those cutoffs?
So for diagnosis of gestational diabetes, there is a special test that we do which is known as the oral glucose tolerance test. It's not that it's such an extraordinary test. It's when you eat a regular meal for about like 1 or 2 days prior to doing the test, and then you come fasting for the test, and then you checked a fasting sugar in the morning, and then after that you're given a load, 75 grams of glucose. You take that, and then the sugar is checked after 1 hour and after 2 hours, and in some cases even after 3 hours, depending on which test specifically is being done. So what we are doing here, like at the MPSHA, is usually the 2-hour oral glucose tolerance test. Now based on that, the values that you get in the fasting 1 hour or 2 hours, those values, they help to define whether you have got gestational diabetes or not.
Does it have any specific symptoms?
With gestational diabetes, it can go completely asymptomatic. The mother may not know at all. She may not have any symptoms of diabetes. Sometimes they do come with symptoms, but most of the times what we see is that they don't have any symptoms of diabetes. And that is why the recommendation is to do a universal screening. Any woman who is pregnant, ideally, as per international recommendations, as per the American Diabetes Association and all basically organizations, every pregnant woman needs to go for an oral glucose tolerance test at least between 24 and 28 weeks of gestation. And if they are at high risk, now what is the individuals at high risk? If they are at high risk, then they have to be tested even earlier. They need to get at least their fasting sugar, or even sometimes an oral glucose tolerance test done much earlier in pregnancy than waiting for that 24 to 28 weeks. So the high risk individuals are those who previously had gestational diabetes. So if a lady had the gestational diabetes in her previous pregnancy, or she had a big baby weighing more than 3.5 kilos in her previous pregnancy, or like she had obesity or overweight before pregnancy, or she has a first degree relative, like a family member which is either a brother, sisters, parents, or children even, who have been diagnosed to have diabetes, or they, like she has been on a very unhealthy lifestyle, sedentary lifestyle and all, with those risk factors, especially superimposed on an obese lifestyle, or if she had high blood pressure or high cholesterol. All these put a person at risk for developing diabetes in pregnancy. So these women need to be tested even earlier than the 24 to 28 weeks of gestation.
Is it possible to have gestational diabetes in one pregnancy but not have it in a subsequent pregnancy?
It is very possible. Actually, we have had females, patients who did not have, who had gestational diabetes in the first pregnancy. Then we control their sugars, and sometimes you need even insulin. But after pregnancy, they've had very good follow-up, and they've modified their lifestyle. Probably someone who was obese, previously, or was not on a good lifestyle, then we modify their lifestyle and all. Sometimes we see that they don't develop gestational diabetes in the second pregnancy. Even without follow-up, it is quite possible that if you had it in the first pregnancy, you may not have it in the second one. But the chances of having it again are much higher.
Does it have any impact on the child, any negative impact on the child.
Yes. If your sugars are well controlled, okay, usually we get good pregnancy outcomes. So the targets are quite strict. Why? Because there are studies which have shown that even 1 millimole increment above levels and continuing to increase above those levels are associated with increased risk of multiple complications related to sugar, like diabetes in pregnancy. And what are those complications? So you can divide them as complications to the mother and complications to the baby. So in the mother, the risk of a preterm delivery is much higher. That means before your term, you get like a delivery, let's say at 32 weeks or 34 weeks. That risk is higher. Again, for the mother and the baby, there's a higher risk of excessive fluid, amniotic fluid. The baby floats in that amniotic fluid, so it could increase in content, in quantity, and that could have adverse consequences on the baby, and especially, again, it could also precipitate a premature delivery. During the time of delivery also it becomes difficult for the mother because the risk of large babies is much higher. So if you've got gestational diabetes, if you're looking at the baby's risks, to the baby, basically you could have a big baby because the baby is using the mother's, like the sugar coming in from the mother, yeah? And if there is a lot of sugar coming into the baby, then the baby's body produces a lot of insulin, and that stores away all the sugar into the body as fat. So the baby will be big in size. That doesn't mean it's a very healthy baby. Okay? Difficulties during delivery, again, what we call as shoulder dystocias are common in this kind of pregnancies. The baby's sugar can be very low at delivery if the mother had diabetes which was not well controlled. Like I said, the insulin is very high in the baby. You could have complications like jaundice coming in, even issues with the hemoglobin, not being normal in the baby, issues with the heart. It could even put a lot of strain on the heart, that excessive insulin that is being produced, okay? So you could have multiple complications in the baby. However, that having had the pregnancy related, diabetes, puts a woman at significantly increased risk of not only developing diabetes in future pregnancies, but also of type 2 diabetes. Almost 50% of women by the age of, after 5 to 10 years of delivery, do tend to develop type 2 diabetes. Again, not only that, independent of type 2 diabetes, there's an increased risk of heart and blood vessel diseases, cardiovascular diseases in the mother later on. If especially they have complications, we don't wait till 38 to 40 weeks for delivery. We sometimes even deliver early on for the safety of the mother and the baby. The mode of delivery is usually decided by the obstetrician gynecologist to decide on the time of delivery and how they'll deliver, whether it will be a cesarean section or whether it will be a spontaneous vertex or vaginal delivery. Based on that, then they usually involve us in their care. So if the delivery is planned earlier on, then the expected date of delivery, usually like at 38 weeks post, then what we do is we give the mother steroids to mature the lungs of the baby earlier. Okay? So once that is done, then the risk of the sugars going high is also very high, because steroids increase blood sugars. So those mothers, we usually admit them to the ward. We monitor their sugars until the time of delivery. And then after delivery, sometimes the sugars do tend to stay higher, like about for 3-4 days, and then they gradually come down. Majority of the women who had gestational diabetes, purely gestational diabetes, their sugars normalize after delivery. Immediately once the placenta is out, their sugars become normal. Okay?
So to avoid these complications, how is it managed? From the time it's diagnosed to the time of delivery and even after?
There are multiple ways of handling it. So most important is lifestyle modification. So every woman who comes to us and every female who has been diagnosed with gestational diabetes, we give them these modalities. So we'll tell them that we first need to focus on your lifestyle, especially on the diet. So there are specific ways. We send them to our dietitian who will direct them on the quantity of carbohydrates that they can eat, the quantity of proteins they can eat, the quantity of fat they can eat, how to include fiber in the diet to avoid a high carbohydrate meal. Then we assess their levels of sugars. As they are monitoring, we tell them to check their sugars, and we assess what they are doing, if they are able to control on nutrition alone or not. So we put them on the right kind of lifestyle. Then we tell them to monitor their sugars. So for a few days they'll check their sugars, then they come back to us. If the sugars are not within the targets that I mentioned, then we usually give them now an option. The best form of treatment for gestational diabetes is insulin. Okay, insulin is given in injectable form, and the best way to give it is in 4 injections. 1 injection is given at bedtime usually or early morning, and then the 3 other injections are given before meals. Usually the doses required are not that high, especially in the early parts of pregnancy, but as the pregnancy progresses we have to keep on adjusting the doses. For females who've got the sugars are not that high, and they're not willing to go on insulin, or they cannot afford insulin, then those are the females that we actually we actually put on tablets. But even them, we always tell them that the the chances of you requiring insulin are still going to be there. And at any point when the pregnancy complicates, when you get excessive fluid, or you see the baby is growing too big for their age, then we immediately switch to insulin. We don't wait before the sugars keep going higher.
What's the worst case scenario where it's not managed?
So during pregnancy?
Yes, during pregnancy. If it's not managed well during pregnancy, what's the worst case scenario?
So we have seen a lot of catastrophic outcomes actually. So there are women we get who are coming into the labor room for the first time ever. They've not gone through their antenatal visits. They don't even know that they had pregnancy-related diabetes. And they're coming in with sugars which are extremely high, okay? And we have seen even stillbirths. We have actually seen, death on the table, okay? We have had intrauterine death of these babies. So that is, we've seen it. We've actually had these outcomes. Unfortunately, that time you cannot do much because already the damage has been done. You see, what the sugars do also over a long term is to reduce the blood flow also to the baby if the sugars are not well controlled. So the blood flow to the baby can get restricted and basically cause the baby to shrink. So some babies, in as much as one of the complications is large for gestational age, if the placenta is not sufficiently supplied with blood, then that can actually cause early placental death, and that then cannot supply blood to the baby, and that can cause early fetal demise or early death of the baby.
Anything else you'd like to add?
Most important is follow-up care, okay? For these women, if you've been diagnosed with either you have diabetes in pregnancy or you have gestational diabetes, the follow-up is much closer with the healthcare team compared to out of pregnancy, or if you didn't have diabetes in pregnancy. So what we recommend for these women is to basically, the moment you've been diagnosed, if it was diagnosed or you had diabetes in the first trimester, then in the first trimester you need to be seen every month. In the second trimester, that is after 16 weeks, you need to be seen at least every 2 weekly. In the last trimester, we actually want to see the patients every week until they deliver. That is the best way to follow up our patients with diabetes in pregnancy or gestational diabetes.